entertained with some infection control questions. Okay, so we will give some chocolates those who win. So please raise your hand when I ask question, right? And we'll hand over a chocolate. Chocolates are also on the way. Fine. So one area of infection control which is often overlooked is how do we dispose the waste in the hospital. So I'll put up a picture and you have to tell me the color of the bin which you are going to put. Fine? This is strictly for the participants, right? Staff are okay. Next level, they can answer. Fine? So I'll start with, there's an arrow here. Which color bin to be used for this? Anybody? Color of the bin? Please raise your hands because which color? Black. Wrong answer. It's a wrong answer. It's a green. Answer is green bin. Somebody said green? Okay. Lakshmi gets one chocolate. We'll give you. Which color bin to be used? Blue. Correct. You'll get one chocolate. Chocolates are on the way. We'll give you. Next. Raise your hands. Which color bin? Red bin. Correct. Which color bin? You need to be a little bit more specific. Nitin, I'm just keeping them entertained, okay? Yellow separate bin with C sticker. You can't just directly dump in any yellow one. Okay? Just one more, then we'll stop. So please write down whoever raised the hands and answer told, we will provide one chocolate for them. Which color bin? Anyone? Yeah? Yellow. All biologicals go into yellow because it can be burnt and no toxicity to anyone. Anyway, Nitin, you can start. So the next few sessions will be done by Dr. Nitin. We'll continue this during my afternoon session. Okay? Thank you. You loaded your this thing? I will just close my this thing.
I'll close it. Good morning, everyone. Apologies for the delay. So, Dr. Chiranjeev's talk on myelioidosis, is cancelled because he could not be here. So the next two talks that we are going to have, one is a talk on CNS tropical infections, and the other is a panel discussion that we are going to have on myths that we commonly encounter while managing patients with tropical fevers. So, CNS tropical infections is a very broad topic, and so therefore all aspects of CNS tropical infections cannot be covered, especially, the most common ones, which is, tubercular meningitis or CNS infections in patients with HIV. But what I'm going to do is talk a little bit about the more classical ones that you encounter in your practice, if you're practicing in at least the southern part of India. So these are basically, an assortment of some of the cases that I've seen in the last few years, and most of them have very classical presentations, and so we can discuss more during the question answer part of this session. So the first case is a 52-year-old male patient, and is an arcanut farmer from Chikmagaluru, Karnataka, has fever, gum bleeding, thrombocytopenia, Can you hear? Oh. Are we sharing the screen or what are we doing?
No, it's coming there, but screen share is happening, right?
This laptop doesn't work properly any which ways. Nothing moves.
Oh, this is PDF, is it? That's
PDF,
why it's not-
PDF.
In this, it should be PPT.
Ah. Thank you. Okay, so this was the first slide, and so we'll start with the clinical vignette again. This is something that you very commonly encounter if you're practicing in this part of the country, but for people who are not from here, there might be a little bit of novelty to this case. So this is a 52-year-old male patient, is an Arcanut farm worker, Chikmagaluru, Karnataka, has fever, gum bleeding, thrombocytopenia. There is altered sensorium, and MRI shows some focal infarct. And the patient improves on its own slowly. 3 weeks later, comes with fever recurrence and severe headache. There are some signs of meningism. You see some cerebellar ataxia, and there are tremors. Patient has gait instability. A CSF is done, shows lymphocytic pleocytosis and elevated protein. So at this point of time, most people who work here know the diagnosis is KFD, right? So these are very classical features of KFD. The first phase is a viral febrile illness. 10 to 20% of these patients can have some hemorrhage. So as you see in this patient, there are some features of gum bleeding. The hemorrhage in KFD has multiple causative factors, including thrombocytopenia and specific factor deficiencies. But one of the hallmark of phase 1 of KFD is that you see altered sensorium neurological involvement in many of the patients. And this has been independently associated with mortality in our previous cohorts. So this is a very important, and this is similar with a lot of febrile illnesses that you will see. For example, dengue, scrub, lepto, all of them have very clearly described neurological manifestations. The thing is that when you talk about neurological infections in general, we focus on the isolated presence of isolated involvement of CNS in tropics. But the idea is that something that comes with such a high burden, acute febrile illnesses, KFD in this region, can have very commonly involvement of the neurological system. So the first phase of KFD involvement is kind of like encephalitis, encephalopathy. So there are a lot of metabolic disturbances happening in the first phase of KFD, which could lead to encephalopathy-like features. But there is also encephalitis, as has been seen in several animal studies and in some of our MRIs, that there is diffuse encephalitis. Also, because there is thrombocytopenia, bleeding manifestations in the brain is not uncommon. Phase 2, however, is very classically neurological. So this is more like an immunological thing in a subset of patients after about 1 to 4 weeks. These patients come with a very classical biphasic pattern where you will have fever and you will have features of CNS involvement in the form of aseptic meningitis and also cerebellar involvement. So this cerebellar involvement is very similar to how you see in varicella. This is transient. You see that so in some of our patients we could see that in PET scan that there was focal uptake in the cerebellum, but this is mostly transient. Most of the patients recover. For initial few of our patients, when we did CSF, we found a lymphocytic pattern. Some raised protein was there. But because we do not do much in these patients, there is no need of antibiotics. When there is a classical diagnosed KFD before, very likely this would be a second phase of KFD. So we do not do routinely CSF in our patients. So again, the diagnosis here was KFD, and like I showed you that the first phase is predominantly an encephalitis, encephalopathy like presentation, and the second phase is an aseptic meningitis, which is more immunological. And you'll see one of the patients where we could see that in the PET scan there was this increased uptake in the cerebellum. So, like I said, this biphasic illness has been described for a lot of febrile illnesses, for dengue or leptospirosis, for example. But it is not as classical as you see in, these are not as classical as you see in KFD. So, people with KFD have very classical manifestations in the second phase. So, almost always we know that this is, KFD. When they come in the second phase. And I have some other discussion on this in the panel discussion part, so I'll not go into the details of it. But in our region, during the dry season, when the ticks are active, January to May, when people come with neurological involvement, either encephalitis, encephalopathy in the first phase or aseptic meningitis, we definitely think of KFD as the predominant manifestation. So this is the second case. The 52-year-old male patient has a newly diagnosed diabetes, comes to you with headache, altered sensorium. Patient has bilateral vision loss, but denies that he cannot see anything. So kind of like Anton syndrome, pupillary reflexes are normal. On MRI, you see this. If you can see the image properly, you will see that there are these white matter hyperintensities in the occipital lobe, and some of it has a tubular linear enhancement. Looks like micro abscesses are there along the white matter tracts. So I'm sure everybody who has worked with melioidosis knows that the diagnosis is neuromyelioidosis. Why it is very important to diagnose this is, classically when you think of melioidosis, you think diabetes. Although this patient had diabetes, but many of our patients with neuromyelioidosis do not have diabetes as a risk factor. So this, the other problem with neuromyelioidosis as opposed to other forms of melioidosis, the more common ones, the pulmonary cutaneous melioidosis, the blood cultures are commonly positive, at least in 50-60% of cases. In CNS melioidosis, blood culture is positive in less than 20% of the cases. The sad part is that even CSF is positive in less than 20% of the cases. We have an hypothesis as to why this is happening, but it's important to know that in big cohorts, in systematic reviews, some of which we have done, the culture positivity of blood and CSF in CNS melioidosis is very low. Therefore, the problem is that it is very important to, one, suspect melioidosis. Now, clinical suspicion becomes a little bit of a problem because, like I said, a lot of these patients have no identified risk factors. So we have had patients who are, this young adolescent patients who have come with short history of acute meningitis like presentation. There are some cranial nerve pulses here and there, and you think of acute bacterial meningitis, but they later on come out to be melioidosis only when you do a brain biopsy. So clinically it becomes difficult. So what helps here is actually the MRI. The thing with MRI is also that if you look at just the flare cuts, it will look like white matter hyperintensities. But if you go into the thin cuts, this patient is a very obvious tunnel sign. But a lot of these patients have these subtle micro abscesses along the corticospinal tract that often if you miss, you will miss if you don't see the thin cuts in MRI. So these are some of the patients who have had neuromyelioidosis, and below is a hypothesis that we have put forward why probably the blood culture and CSF culture is negative in neuromyelioidosis is because probably the bacilli is going through the cranial nerves and the spinal nerves, and there are mouse experiments to show that. And this is something that is very interesting that was also seen in a recent report from Vellore, where they had a few patients who all visited a same dentist and had neuromyelioidosis and died, some of whom did not have any risk factor for melioidosis. Then later it was identified that the water that was used during the dental procedures had the melioid bacilli, and therefore very likely through, and a lot of them did not have blood culture positivity. So very likely a lot of these bacilli traverse through the nerves, the hypothesis that we have given. So this is very important. A lot of these patients have been diagnosed with either autoimmune encephalitis or TB or even malignancy, and were either not treated or given steroids and worsened. So this is something to think about when you have, if you are working in melioid endemic region. In India, probably most of the regions are melioid endemic. So With melioidosis, you know that it's endemic in, previously we knew that it's northern Australia and Southeast Asia, but you know that the latest projections say that the highest burden of melioidosis is in South Asia. And as the awareness is increasing, more and more people are diagnosing melioidosis. And CNS involvement probably is a little higher in the Indian cohorts, probably because of the higher prevalence of the BIM-ABM allele. The clinical features are usually, they come with, you know, these acute onset bacterial meningitis-like features with multiple cranial nerve palsies, and with hemiparesis because corticospinal tract is involved. So the pathway that we envision is that, you know, it either travels through the sinus, fifth cranial nerve, goes up brainstem, thalamus, and then corticospinal tract, and it forms these microabscesses along the path leading to the formation of these the so-called tunnel sign. The diagnosis, like I said, radiology is very, very important in neuromyelioidosis. Blood culture, obviously, you should send. If it comes positive, it's great. CSF culture, if it comes positive, it's great. But most of the times, the definitive diagnosis has been made by a brain biopsy, which in many settings is difficult. The treatment of neuromyelioidosis is, like, you know, for melioidosis, the treatment is long. So there is an intensive phase where for 2 to 8 weeks, this is in general for melioidosis, you give ceftazidime or meropenem, but for neuromyelioidosis, you need to give a higher dose of meropenem for a longer duration. So what has been agreed on, it's not based on very solid science, is that you give 2 gram meropenem TDS for 8 weeks, and this is followed by a cotrimoxazole, oral cotrimoxazole for 6 months. Now again, there is no clear-cut defined protocol for management of neuromyelioidosis, but you know, you repeat an MRI after every 4 to 6 weeks and see how the involvement is. So this patient, for example, he received, you know, 2 months of meropenem followed by 6 months of cotrimoxazole, and at this point of time, he's able to see, and there are some problems with fine movements of the hand, but as such, he's mobile and fully functional. This again is a case who has come with, you know, acute onset fever and has neurological manifestations in the form of GTCS. You see that there is diffuse blanchable rash and thrombocytopenia, and you see on the MRI these bilateral symmetrical thalamic hyperintensities. So, do you know the diagnosis here? Dengue. So this is the so-called double donut sign. The center reflects the hemorrhage, and outside there is a little bit of edema. But this thalamic involvement is something that has been seen with a lot of flaviviruses, including Japanese encephalitis and West Nile. So depending upon what is the predominant manifestations, you should think about, in fact, you should think about all flaviviruses when you see a thalamic involvement for multitude of reasons that will not go into. But this is usually what you see in a very classical case of, you know, dengue encephalitis, when you have these thalamus involvement in the form of a double donut sign. But not necessarily that all patients will have it, but a lot of patients with dengue have these, you know, diffuse encephalitis that needs good supportive care, to say the least. And the mechanisms are again multifactorial, including metabolic disturbances, but CNS involvement, direct viral involvement has also been demonstrated in dengue encephalitis. So this is the fourth case. So this is a female patient who came to us. She's an immunocompetent female patient who was, you know, writing for the MBBS exam, you know, the NEET exam from Karnataka, and she had this fever, headache, neck stiffness, and photophobia, and she was managed outside, as a lot of patients are managed with empiric antituberculars. And there's nothing wrong with it when somebody comes with a chronic meningitis. You think of TB as your first possibility. She underwent a dental procedure 2 months back and had some very past history of remote nasal surgery. But when we saw the patient and did a CSF, it had lymphocytic pleocytosis, elevated protein. Glucose was normal. The elevated protein and lymphocytic pleocytosis kind of, you know, makes you think that maybe TB is still a possibility. No basal exudates in this patient. All tests were negative. TB, CNS involvement of TB is possibacillary, and CSF gene expert is often negative. But all tests were negative: bacterial, TB, viral, cryptococcus, everything was negative. And MRI showed this diffuse leptomeningeal enhancement that you are seeing. So anyways, with the increase in, acanthamoeba encephalitis reports from Kerala, we have been acutely aware of that. So we have started doing CSF wet mount for a lot of these patients. And so this patient also, the wet mount showed the trophozoites of acanthamoeba. Since then, we have seen a lot of cases of acanthamoeba, and often the classical risk factors for acanthamoeba are not noted. So classically, if you see historically, acanthamoeba has been more commonly reported from immunocompromised patients with a very high mortality. However, what we see is a lot of these patients are immunocompetent. Sometimes you have this, clear risk factors are not there. Here again, we hypothesize that acanthamoeba is also known to go through again sinuses and invade the brain. So we hypothesize that probably the dental procedure was the risk factor for acanthamoeba here. Some patients, the history of ritual ablution has been there, but that is present in a lot of population all across the globe. So pinpointing that as a risk factor is very difficult. So what we now do is any patient with chronic meningitis, we think of acanthamoeba definitely as a possible etiology. The other thing is that some of our patients have come with actually basal exudates in MRI, and then later on they have come out to be positive for acanthamoeba. These patients were negative for TB, but the situation is a little complicated because colleagues from Kerala tell me that in some of these patients, TB has also been positive, and you know that acanthamoeba is a protozoa that can carry a lot of these organisms inside, so TB, listeria and all that. So co-infections are a possibility in acanthamoeba. Makes the situation a little bit complicated. So anyways, something that helps if you have a patient with chronic meningitis and the patient is not improving, at least you should do a CSF wet mount. The sensitivity of that wet mount is a little low. So PCR facilities, for example, are available in our institute and are available in many institutes across, at least in Kerala as of now. So this is something that you should suspect. And our finding with whatever cases that we have seen is that most of these patients, barring one or two, are immunocompetent young adults. So, and classical risk factors are very commonly absent. And a diagnosis like this will save the patient from, prolonged anti-tubercular therapy and also likely mortality. So, one is that this is called, this acanthamoeba encephalitis is called granulomatous amoebic encephalitis. Classically, there are two, amoebic encephalitis. One is the primary amoebic encephalitis that is due to Naegleria, very acute fulminant course, people die very fast. Very, little evidence on any particular therapy helping them. The second one is this granulomatous amoebic encephalitis, because here actually therapy has shown significant improvement across the Kerala cohort. They have some, around 200 cases. West Bengal has some 30, 40 cases where they have shown good improvement with the cocktail of therapy that they have tried. And we have our own regimen that we try also, and with good benefit. Most of our patients have survived, barring one patient who had, simultaneously CNS lupus as well. In which way, this was the second patient that I'm showing. You can see clearly that there is, basal exudate. There is this encasement of the basal vessels. This is, if you see, there is some hydrocephalus also. If you see, this looks very much like TB. But the patient was not improving on ATT, and we clearly, if you can see on the top, these trophozoites of acanthamoeba are changing the shape. So this we could do a PCR and culture and also prove that this was the so-called granulomatous amoebic encephalitis. The other thing is this terminology, granulomatous amoebic encephalitis, has a little bit of problem because it kind of suggests that all patients with acanthamoeba have granuloma formation, which is not true. So we reviewed all the cases of this so-called granulomatous amoebic encephalitis, and 50–60% of the cases only you can see granulomatous. And amoebic also includes Entamoeba histolytica, which can also cause encephalitis. So little, uh, you know, the terminology is not that great. So we wrote a letter basically to Lancet where we suggested that it would be good to classify them as flagellated and non-flagellated. So flagellated is the Naegleria primary amoebic encephalitis, and non-flagellated are these Acanthamoeba, Balamuthia, Sapinia, these ones. Anyway, so more than the taxonomy of the things or terminology of the things, it's important to suspect and diagnose this. So the thing is that we have, because of this poor sensitivity of gene expert in, you know, these possibacillary samples like CSF, we have a tendency to overdiagnose TB and give AT to all of these patients, which is correct, which is not wrong because they have poor sensitivity, and so you want to cover for TB. But it's also important to suspect other infections and simultaneously try to make a diagnosis in these patients. And this is what I was talking about, what it's not obsolete, this is what AI did on its own, but this is what the terminology that is used, but we propose that, you know, this creates a lot of confusion. Anyways, in terms of Acanthamoeba versus Balamuthia, most of our cases in India has been with Acanthamoeba. But in the systematic review that we did, basically, if you compare Acanthamoeba and Balamuthia, historically, in the published literature, Acanthamoeba has more classically been associated with immunosuppressed patients. But you know, at least in our experience, in the Kerala experience, this immunosuppression is not a significant predisposing factor. So this is something that has to be kept in mind. And surprisingly, the mortality in Balamuthia was still high, even if it was immunocompetent individuals. So in general, you know, these Acanthamoeba encephalitis, you know, the entry route is probably either through, you know, directly through nasal mucosa, olfactory nerve, CNS, or like I said, in this case, it could have been some dental surgical entry, or it could be some skin lesions where it could enter, or, you know, contact lens, then through that entering into the CNS. But there are a lot of possibilities. Were very, very difficult to pinpoint what was the exact risk factor that led to the occurrence of granulomatous acanthamoeba encephalitis. The Kerala group has an hypothesis that probably exposure to well water is a risk factor, but everybody in rural area drinks water from wells, so it's very difficult to again pinpoint that. But again, the main take-home message from here is that if they have a chronic meningitis patient, apart from TB, definitely suspect Acanthamoeba encephalitis. The microscopy is a simple method that often helps in the diagnosis of this GAE. Not very difficult, you just need a trained microscopist, and that microscopist has to spend some amount of time in this. But culture, PCR, all these things are not very difficult to get in today's day and age. The treatment is something that there is no clear-cut described regimen for Acanthamoeba encephalitis. So what we use is what we called as the Mars regimen, but there is no clear terminology like that. So we use miltefosine, azithromycin, rifampicin, and cotrimoxazole. This is something that, because these patients often require long-term therapy, so we try to give something that has, you know, good bioavailability, can be given orally, and is not very expensive. So miltefosine is not very expensive, freely available. There are papers that the CSF levels of miltefosine are not very high, but the brain tissue level of miltefosine is usually good. So miltefosine is something that we give for most of our patients. Azithromycin, rifampicin, and cotrimoxazole. There you can add fluconazole and metronidazole as well, but long-term metronidazole therapy most of our patients do not tolerate. If the patient is not able to take orally, then we bring in metronidazole. But the idea is to give like a 3 to 6 months treatment duration. Again, that is not something that is standardized, but this is something that you know, most people who work with Acanthamoeba do. Now, this is another case. 42-year-old female patient has Ivan syndrome, is on prednisolone for a long time, has progressive right side weakness, and on admission has a GTCS. And you see this MRI, this multiloculated ring enhancing lesions in the left parietal lobe. And you think the diagnosis is? This is again, so for people who do tropical medicine, you can take in any infection and call it tropical infection as long as it happens in tropic as well. So this is not necessarily a tropical infection, but nocardiosis is something that is not very uncommon in India. It's again a big TB mimic. So again, the usual tendency of when you see brain abscesses, you think of bacterial, you think of TB, but nocardia is something that is not very uncommon. Why I wanted to put this in a talk on CNS tropical infections is that a lot of our patients have increased reports of cotrimoxazole resistance, which is the main treatment that you give for nocardiosis. And we did again a systematic review for all published cases from India, and there is increasing reports of cotrimoxazole resistance. And in many of the labs, people don't report cotrimoxazole resistance. It becomes a little bit difficult. So it's very important to know whether cotrimoxazole is working or not, because that is one of the background regimen, main important medicine that you give for a prolonged duration of time in patients with nocardiosis. So this is something that one should keep in mind. And so when you have nocardia in the brain, you should look for it in lungs. The vice versa is, again, depends upon how resource intensive your setting is. So, less than 10% of the patients with pulmonary nocardiosis will have some asymptomatic brain abscesses sitting, inside the patient. So, if you have an availability, if there are no severe cost constraints, it's a good idea to image the brain as well, because classically you want to give at least 3 medications that work for CNS nocardiosis. So, this is one case that I have just quickly showing, and I'm not going to go into the details of it, because CNS involvement in HIV is an entirely different topic and has so many possibilities. But again, this is not a tropical infection. You see something like a Milky Way sign here in a patient with left UMN palsy, and you see, if you see asymmetric white matter hyperintensities in a patient, HIV patient with advanced immunosuppression and some focal deficits, and this Milky Way sign, you think of PMN. So JC virus was positive in the CSF for this patient, and the problem is treatment of PML is very complicated, very tricky, and long-term outcomes are poor for these patients. But anyways, I'm not going to go into the details. This is probably the last case, and this is very interesting because we had a patient who came with, again, fever, headache, and MRI, had some ring enhancing lesions, and outside was reported as, infective, which is often how MRI and CT is reported, infective versus non-infective possibilities. But anyways, the patient was started on ATT, but there were, in the MRI, some of these lesions, it looked like they had some scolex. So, but it was an outside film and we couldn't see properly. So one quick thing that we did that could help was that we did an X-ray of the thigh, and you see these, rice grain calcifications. So these are the calcified worms that you could see in this patient, and we confirmed the diagnosis as NCC. Later on, we did a good quality MRI, and that showed that there is definitely NCC in this patient, but in resource limited setting, something like this can be helpful. Anyways, I'm not going to go into the details of, again, NCC, but the management, one of the important part of management of NCC is that don't be very trigger happy with antiparasitic agents. See first whether there is any ventricular involvement or ophthalmic involvement before you start antiparasitics. Steroids are very important for a lot of these infections, at least initially. Later on, you can start antiparasitic. This is again a similar case where steroids are very important. So somebody who came with a 26-year-old male, came from northern Kerala and had severe headache, nausea, vomiting. He had a history of consumption of this raw monitor lizard tongue, and gallbladder. Somehow this is believed to give, increase virility. And he had this clothing discomfort, he had this pain all over the body, and he wanted to be, bare chested. But there was no other meningeal signs, and there was eosinophilia in the blood, and the CSF, the diagnosis is eosinophilic meningitis. Most of the patients in India are due to angiostrongylosis cantonensis. There are some cases of gnathostoma as well in India, but most commonly it is angiostrongylosis cantonensis. This is something that we did recently in terms of the number of cases of angiostrongylosis from throughout India, and you see that most of these cases are from Kerala, and history of monitor lizard consumption has something to do with it at least. So this is something that the Trivandrum team has coined as a dress sign, a good catchy name, but basically there is some sort of cutaneous sensory neuropathy in these patients that gives some allodynia like sensation. So any light touch can also trigger pain and discomfort. This is something that around 50 cases have been reported from India. Important thing with this acute eosinophilic meningitis is that, again, the treatment is not antiparasitic agents. You need to give steroids, probably for a long duration, and later on you can try antiparasitic agents, but mostly the treatment is the worm dies on its own, so you need to give just anti-inflammatory in the form of steroids, so that this acute crisis you can cross over. And peripheral eosinophilia is something that is helpful if you're not able to do CSF in these patients. And PCR, so there are no microscopy that can be helpful here in these cases. So PCR is the investigation of choice. So many centers are able to do it. We send our cases to Kerala or Vellore, and it's important that the routine biofire panels will miss this. So it's important to suspect angiostrongylosis cantonensis. It's not as uncommon. It's not a one-off case. It's not very uncommon, especially in this part of the country. So, and MRI brain is mostly, for whatever we have seen, are usually normal. And like I said, initial treatment is steroids, and later on, once the patient has recovered and you want to be sure that you are killing the worms, you can give albendazole if you want. So this is my this was my last slide. If you have any questions, I'll be happy to answer. And we'll quickly move on after this to the panel discussion, which is going to be quite a repetition of what we did throughout the morning, but we are happy to discuss more during the panel discussion. Huh. Last slide. No, only scientific questions are allowed. We will have a separate session on the science of photography. This is probably not the session. But a lot of people who are here in this image are sitting here. So, but if there are any other questions, otherwise we'll move on to the panel discussion. So this is common. So to crib about bacterium intolerance, and it happens with a lot of diseases. One is that cotrimoxazole or bacterium is a life-saving drug, and you should try as much as possible to give bacterium in these cases, because these are the first agents of choice, cheap. The thing is that a lot of this fear with bacterium comes from the knowledge that we have on HIV patients. And HIV patients, cotrimoxazole it has been documented that there is a higher propensity to have side effects. But in non-HIV patients, the side effects are not that common, let's say. There are problems. So, right. Right. So, right. Right. So the thing is that what are the side effects with cotrimoxazole, and so each of the side effects have different ways of management. There are some ingenious methods. So for example, something that Praveen started doing was for hyperkalemia with cotrimoxazole. So we started giving fludrocortisone to our patients, and so we didn't have to stop cotrimoxazole for any of our patients because of hyperkalemia. Again, in patients who have preserved renal function at the baseline, acute kidney injury has never led us to stop cotrimoxazole. But there could be, again, skin reactions, which again, like Dr. Shantan is saying, that we can try with desensitization protocols. But there are cases and not very uncommon to have cases where you're not able to give cotrimoxazole at all. So in that case, the best alternative that we have for oral maintenance therapy with for milieu doses is doxycycline and amoxiclav, but they are alternatives. So there are head-to-head trials where doxycycline has performed worse as compared to cotrimoxazole. So uh, what we do is if we have to give, we give doxy plus amoxiclav. Again, this is not something that is clearly shown in an RCT, but there are alternatives available to try. But what I want to imply here and suggest very strongly is that if you can use cotrimoxazole, try to avoid using cotrimoxazole, because I don't know if Ankit is here or not. They give minocycline for all the patients of milieu doses, something that is interesting, but not something that I will do to avoid complications with cotrimoxazole. Huh. So again, so whatever we have seen, we haven't found any specific MRI findings for angiostrongylis. Uh, Again, nothing specific as such. Sometimes there could be these non-specific punctate hemorrhages or lacunar infarcts or some white matter hyperintensity here and there, but nothing specific in terms of that says that this is angiostrongylis. Dr. Neha, you want to add something? So, so I'm aware that there is one report of where levonorephoxacin was used for milieu doses, but it's one report, one case report on levonorephoxacin for milieu doses. I would not use it personally because there is a whole lot of evidence for a lot of other drugs for milieu doses. Doxycycline performs poor, but it is poorer than cotrimoxazole. As such, the outcome with doxycycline is still better. So most patients tolerate doxycycline.
So, I mean, just to add, I have used in 2 patients. Both of them failed doxy and had relapse. And I had no choice. I gave me doxy, then sometime mino too, but then they had like bad ankle vasculitis patient. So I added that, and it has so far so good. 1 year follow-up, no relapse.
Nice. No, this is interesting.
But no, I just wanted to know if other people are doing something that I'm doing. That's all I wanted to know. No, we are. It's.
Yeah, no,
it's
definitely it's a good idea to report.
Yeah,
So as of now, now I know about 3 cases of levonorephoxacin use.
Okay.
But the thing is that again, the evidence is very poor.
I agree.
So what we do is we give doxy and augmentin, we combine it both, and we give to our patients. Again, it depends upon where the infection is, how long do we need to treat. The other thing that can be done in these cases is where if the patient can afford, so there is now data from the Darwin cohort that if you prolong the intensive phase therapy, you can still get away with a smaller duration of eradication phase.
Yeah.
So most of our patients are poor, but if we can manage, we increase the intensive phase because the intensive phase is more easily managed. So not a lot of issue with either meropenem or ceftazidime. So we increase that phase and then try to manage with whatever we have in terms of the oral therapy.
No, I just wanted to ask if others are doing
Yeah,
that.
no, in our center at least, we do not have levonadifloxacin available, and now it's available. Huh?
No, no, I don't disagree. No, no, this was like a pressed against the wall type of a
No, no, no.
situation itself. I
I
mean,
understand that part. Uh, the my the thing with anecdotal evidence is that I would you know prefer that if we can, because we have enough number of melioidosis cases. So if there is an RCT done, even a small RCT, that would be very helpful, because cotrimoxazole adverse events is a problem. So I agree, but
doxy fails more. I mean,
doxy relapse is
relapses
higher.
more high. Matlab, I have not seen them doing very well most of the
So
time.
what we do most of the times is, because, so there was this Mirth trial where they compared doxy versus combination. So it was still okay. It depends upon how much the load is, where the organism is, how long was the intensive phase therapy given. These are a lot of things in terms of fluoroquinolones, let's say. Not levonadifloxacin. In terms of fluoroquinolones, the data is not very great in support of melioidosis. So, in terms of in vitro data, both will be similar, doxy, levonadifloxacin. So, in vivo data has to come for it to be used more broadly. So, in situations where all the other, because again, like I said, Ankit is not here, but they are using minocycline very commonly for patients. So again, what I tell him is that it's important to report it for others to understand, and then we have to plan these larger cohorts where we can use these drugs to have a better data. Problem with, again, levonadifloxacin as a whole, the drug, is that the data on levonadifloxacin is not that great. It might be a very good drug, but the evaluation has not been great. So if we are able to prove that, then it would be very helpful. So are there any other questions? So then we'll move on to the panel discussion. So for the panel discussion, I want to invite Praveen, Dr. Shayantan, Dr. Sharda, and Dr. Bharti. Sorry? So we have a session on, busting the myths in tropical ID. We are going to discuss tropical fever. Most of it has already been discussed throughout the day. The idea is to kind of take perspectives on these things. So these are, some of these are commonly encountered statements that you get when you are practicing, some of which is myth, some of which is not, and there could be difference of opinion here. So the idea is to have a panel of experts who are going to talk about, yeah, Mike. So the idea is to have a panel of experts who can put things in perspective. So the time we have for this is half an hour. So Dr. Shayantan, please keep your thing to the minimum. No, just joking. But so we'll start with the panel discussion. I'll show the cases, and then we can have each of us just talking about what do you think is right or not, or what are the caveats in this broad statement that I'm going to give, and then we can discuss more. So, so usually the thing is that there are some first is that there are some real world statements that people give. My teacher, my teacher's teacher, my teacher's teacher's teacher used to say this, so I follow this. But the trial has, there are now better data. There is systematically evidence has been synthesized, or there are trial data available. So the idea is to how to avoid trap. Some of these statements might be right, some of them might be wrong, but it's entirely what do you think has to be done. So the format is basically that I'm going to show a case vignette, then I'm going to give a statement, and then I am going to ask the panelists what they think. There are some evidence that I'm going to show, and then the take-home messages which all panelists should endorse. Right? So this is again the same case that I showed. Everybody knows this case. I showed that somebody has come with fever, altered sensorium, there is some neurological involvement. Platelet transfusion, so platelet goes below 20,000 over the 5-day period. And so the question is that platelet transfusion is needed in dengue when the count is below 20,000. So this is a very broad statement. Some of the guidelines state that. And so the idea is that, do you think that statement is true or myth, or are there any caveats? So we'll start with Dr. Sharda.
So what we were practicing and what we learned was that, you give it when a patient with dengue is bleeding, and or if the patient's platelet count comes down to, some folks say 20,000, some folks say 10,000. So that is really not very clear with respect to that. But in practice, what we generally do is that if there is someone who is having active bleeding, then we transfuse no matter what the platelet count is. And then, of course, if it is less than 10,000 is what, we saw in some of the Indian guidelines, and then 20,000 in, I think, the WHO guidelines.
Right. So active bleeding, I think everybody agrees that if there is active bleeding, then there is probably benefit of transfusion of platelets. When there is no active bleeding, here in this case, it's a little tricky because the CNS shows a double donut sign, which could suggest that there is some bleeding, but there is no clear bleeding anywhere else. So in
Dr. Sharda, I would like to ask you, what if the first episode of bleeding is in the brain? That is the defense most of the people use. You are not transfusing at 20,000, but what if, and waiting for the patient to bleed, what if the first bleed is in the brain? So
that is the issue that we generally do face, but we still do not have the guidelines to say that, just transfuse just like.
No, so the thing is that I am the moderator. So let me ask the questions. Okay.
So this is a very interesting scenario.
This is so the idea, the thing is that what you said was very important, that there could be.
So I'm a panelist. Let me answer. So this is a very difficult situation bedside to whether to transfuse or not. To answer this, we actually did something. So if the patient is likely to bleed, that should be a real-time bleeding, which we can see in probably thromboelastography. So if you are looking at the ratios of MA/R, and you had a paper in which you have given a cutoff of the TEG parameters using which you can probably predict the bleeding. This case is interesting because the MRA pattern we are seeing is called acute necrotizing encephalopathy. With dengue, we call it as DANE, which is because of the cytokine, excessive cytokine response. And bilateral thalamus involvement will be there because that is the area which is highly metabolically active, leading to necrosis and some bleeding. So platelets are not immunologically silent. When we transfuse platelets, it actually leads to immunological activation. So in this patient, if you are transfusing, it is possible that you are harming more than doing something good for this patient.
The reason why I wanted to come to you last was that most of these cases you know, and we have argued over this a long time before. So we will start with the panelists who people have not heard that much. So Bharti, do you have anything to add on to this?
Yes, sir. So I think, yeah, most of the, from what I remember, the retrospective reviews of transfusing when without any active bleed and platelets on the lower side, there's not too much difference in active bleed in dengue. So there may be other reasons for bleeding other than just thrombocytopenia.
Right. Two very important points that you have raised is, one is that there was an RCT actually where in platelets below 20,000, people who were not bleeding, they transfused and did not transfuse, and there was no difference in terms of outcomes. And the second thing is that bleeding in dengue is actually multifactorial. The problem is that when dengue happens in endemic areas, there are these huge number of people, there is a lot of media attention, and there are some guidelines that suggest that you transfuse when the platelet is below a certain cutoff. And so at that point of time, it becomes a challenge to not transfuse, even if what Praveen is saying makes sense that in some of the patients actually transfusing platelet might be harmful. And then the caveat of understanding and using thromboelastography in these patients. But it's again a challenging thing. Dr. Shantan, do you have anything to add?
Small comment. I have been following dengue for almost like last 9-10 years. And what I have found, in severe dengue, I have not seen people dying bleeding, you know. So yes, there are a few cases of hemorrhage in the brain, but as Praveen rightly told, that this is mostly an encephalopathy. How we see patients worsening in the at least last post-COVID, I would be saying last 2-3 years in West Bengal, is mostly by multi-system inflammatory response, where we have very high ferritin and LFT. So I think we have to come out of the platelet trap in dengue and go to the, you know.
National data shows there are no mortality of dengue in West Bengal.
No, that's not true.
Because he's there.
Yeah. So I'm far from West Bengal, and I don't think that I will be, put into something legal problem. But that's not true. That's not true. We have seen mortality in dengue in West Bengal, and the cases are actually one of our assistant superintendent in the ID hospital diet of dengue. So I think the main last message that should go out of this is probably we should shift to TEC and stop, regularly seeing a platelet and fueling people's panic by the platelet count.
Right.
Yeah.
I absolutely agree. So platelet is possibly a useful adjunct to the therapy, but what we make of platelet is that it is something that is the most important thing, and people keep on chasing platelet, whereas hemodynamic management of dengue is probably more important. Properly managing that is more important than platelets. And if patients are bleeding, then again that can be multifactorial, and there are nuances that people should understand. But running after platelet transfusions in asymptomatic patients who have low platelet count is something that might not be of great help. So we agree with this message. So I'm now going to show the evidence and the pathophysiology. We'll move on to the second patient. So again, this is something that there is a newer evidence that has come again in the recent time on this, in the last 2-3 months. This is very interesting, and this has been in debate for a long time. So this is patient who has come with an SCAR, scrub typhus is positive, and there is some myocarditis. Patient has ARDS or some form of heart failure also. So this is a severe scrub typhus, and you want to give doxycycline and azithromycin combination. So the question here is that combination therapy with doxy and azithromycin is required for scrub typhus, especially severe disease. This is important in this patient because this patient already has myocarditis. Do you want to give an azithromycin in this patient? What is your usual practice? So we'll start with Dr. Sharda.
Okay, in our practice, we do not really prescribe both the drugs. We've had this conversation also that there are some methodological challenges in the trial which did this doxy with azithromycin, and thereby we usually give doxycycline only. The focus in these patients is more with respect to the critical care management and ensuring that when we have the immune mediated autoinflammatory sort of situation that happens, we try to take care of those. We are trying to give more of, steroids if required, and Plex we have done in some patients, but this combination not necessarily, though I do have colleagues who stand by it and say that we have to give this just because of that one trial which has come out in the
But
news.
are you comfortable anyways in giving azithromycin in somebody who has myocarditis?
Not really, because there is a possibility of arrhythmias, QTC prolongation, etc. So I would give doxycycline to this patient. And
So an
not
important point here is that that intensive care management of severe patients is not only giving a magical bullet, but supportive care is very important, which can vary from place to place. But
the concerns which we generally have with patients with scrub, just like with any of the other tropical illnesses in the ICU, is that there is this, similar to the sepsis phenotypes which are coming out, there's probably a lot of phenotypic variation, and I think Praveen will agree with me on this, that there's a lot of phenotypic variation. I will not give him the mic. So that is probably what we need to look at. Who are those hyperinflammatory patients who need more of steroids and other immunomodulatory management, and not just this combination. And I'm definitely not comfortable giving azithromycin in most of our critically ill patients, because there's a lot of, unless it is absolutely necessary, of course, because there's a lot of drug-drug interactions which are there. So doxy would be the drug that I would give. So.
right, Bharti, do you have anything to add?
Yeah, so I think ma'am has covered most of the points. In practice now, at where I work, they are using two drugs for anybody with severe scrub typhus, and it's based on the sense difficult to persuade them from not using dual therapy in patients with severe scrub typhus, along with appropriate critical care, like she mentioned.
Right, Dr. Shantan, you have?
So what we did for severe doxy, we have actually used doxy in a higher dose. 300 to 400 milligram of doxycycline per day.
This
IV.
is based on some trial evidence?
No, this is based on two things. One is
No, I don't want. I'm not seeing, ma'am.
basically
I'm only post talking.
doxycycline
I'm already having some
toxicity.
discussion.
Acute hepatotoxicity is not that much reported. Doxycycline is usually a drug where higher dosing is quite allowable. And if you see all the data based on azithromycin and doxycycline is a magic for orientia in all the cases that we have
No, but then why limit to 400? You can give 800.
No, that higher doses have
No,
never
but
been tried.
has there been any paper where 100
Not in
versus...
scrub typhus, but doxy higher doses has been used in other
Like?
European. There is, I think, Lyme or no. I'll get back to you. But 400 milligram per day doxy has been safely given to patients.
Interesting approach. Praveen, do you have anything to add?
Yeah, so obviously in a trial setting, we will be recruiting the patients without myocarditis. So by default, this patient is not where you should be extrapolating the trial
Right.
data. For this patient, we'll
Right.
probably just give doxycycline.
Right.
And second thing is, when we are giving antibiotics, a combination of antibiotics, you are basically trying to kill the Orientia susugmasi faster.
Right.
In that trial also, the combination therapy is shown to kill it faster.
Right.
But the question is, do you really want to kill it faster? Or how much it will make any difference if
Right.
you kill it 1 day or 2 days? That is
So recently, so they have come up with another interesting paper. So the initial paper was definitely a great exercise, and it was very interesting. They have come recently with an interesting paper where they wanted to see the intracellular concentration of doxy and azithromycin in these patients, and what they found was that the
Azithromycin
intracellular
has a
concentration
very
of
high
doxy was higher, very high, and sorry, azithro was very
Azithromycin
high,
concentration
and doxy was extracellularly very high. So the conclusion that they came in this paper was that one drug is intracellularly active, the other is extracellularly active, and so probably the combination is working because both drugs are acting in two different realms, and so theoretically it might make sense. What do you think about that?
The thing, as Dr. Sharda ma'am rightly pointed out, in this patient, the issue is not what antibiotic you are going. It is not going to make much difference.
Right.
So in that trial also, it is a composite outcome where patients had a faster improvement in bilirubin and creatinine. And those are just numbers. Like, this is not what we are really looking into. Probably we are looking into a mortality benefit. I don't think a combination of treatment in that trial also didn't show mortality benefit. So you probably decrease the duration of hospital stay. But in this patient, if you use azithromycin, you might increase the mortality also. This patient is definitely not for a combination therapy.
Right.
Routinely, whether we have to use combination therapy is not is for debate.
Right.
But I would not use.
Right. So the take-home message probably would be it's important to understand the trial and the context, the inclusion-exclusion criteria of it, and what was the outcomes that they studied in a patient that does not have myocarditis, where there is no contraindication for both doxy and azithromycin, where if you're using both, it might be okay. But in patients where there is a definite contraindication for one, insisting on using a combination for a trial that does not support benefit in mortality or time to effervescence, that might not be a great idea. Yeah. We all agree with this.
Just, it was tried with 600 milligram 5 days on gonococcus has been tried a lot in older literature. So safety of 600 milligram doxy per day has been
objection I had was not on the safety, but was on, see, the point is that IV doxycycline is still expensive. So a lot of these patients do not get oral drugs. So if you are giving an IV drug with increased costs, even if it is safe, my idea is that we should have some evidence to support that. That was the idea. But again, case-to-case basis, we can decide what we want to do. But the idea is that over the years, so there have been, so when I did this systematic meta-analysis for doxy versus azithro in scrub typhus, there were 10 trials that studied doxycycline, and none of them used a dose. So some of them used a loading dose of 200 mg, but 100 mg BD was the standard dose for doxycycline. For me, it works well anyways in that dose, but this is an interesting idea to explore whether increasing the dose of doxycycline has an impact on not only scrub but other agents, like you're saying gonorrhea and others. But so we agree that this is something that has to be taken in context. So we'll move on to this third case, where this is a patient who has come with fever for 10 days. There is no eschar, but IgM ELISA is positive for scrub. PCR is not done, NS1 is negative. So the clinician documents that this is confirmed scrub typhus and starts the patient on doxycycline. But the patient does not improve after 5 days. So the question here is that single ELISA positivity confirms the diagnosis. I'll start with Dr. Shayantan this time.
No, definitely a single ELISA positivity would not confirm diagnosis. We are getting scrub ELISA false positivity as well as lepto ELISA false positivity in other culture proven or PCR proven cases of other diagnoses, as we were discussing in enteric fever, etc. So I won't label it as this thing. Specifically, you know, patient when already received doxycycline for 5 days and no improvement.
Very important point. So most patients with scrub improve with doxycycline, and this is something that people have to understand, that IgM serology is a very, very non-specific test. So if you don't know what IgM serology was done, how was it done, and the caveats for each of the different diseases, it becomes very difficult to interpret it. So traditionally it is said that you do a paired serology, but clinically it is not possible. Anybody who has come with acute febrile illness, you cannot do a paired serology with 4 weeks apart, right? So that is something that is not possible. But IgM ELISA that is positive, that information alone is not sufficient. So there are other things that we need to know. But Bharti, do you want to add anything in it?
No, yeah, I think yes, sir has covered it, and usually scrub, like you said, does respond very, at least the fever does respond quite quickly with doxycycline. And I think most of the other tropical infections we are talking about do have some cross-reactivity in their serologies. Right. So I think in this patient we'd have to look for an alternate diagnosis.
Right. It's also important to know that what cutoffs are the microbiology labs using. So the traditional cutoff for IgM ELISA for scrub that the kit prescribes is an OD value of 0.5. And this is important for everybody who's practicing, is that in India, a lot of healthy volunteers have an OD value of more than 0.5, and therefore this frequent issues of background positivity. So we did a study where when we increase the cutoff to 0.9 or 1, the specificity increased by a lot. And this is something that people are more aware in terms of galactomannan. When you increase the galactomannan, cutoffs, the specificity increases. Same with scrub. The cutoff has to be regional. So most places, the cutoff has been seen now to be 1. So it depends. It's very important to know that what your lab is using, what cutoffs are they using, and have they determined this for your region. This is one of the reasons for this frequent false positivity. Scrub ELISA of with an OD value of 1 or 0.9 or 1 has a much higher specificity. Does it depend which test you are using? Is it ELISA or immunofluorescence assay or a rapid diagnostic test? Will that make difference? So what is your preference, Dr. Shant?
So if I have the luxury of immunofluorescence, I would go for it, but I have my Pan Bio ELISA kit, and I study your literature, and we have increased it from, you suggested 0.8, 0.8 or 0.9, we do it at 1 in our
right, which is what most regions now agree on. This immunofluorescence, again, this is something that I wanted to point out, was that immunofluorescence is very subjective. So people who do not understand that well or do not know how to see, and especially with something that is very observer dependent, immunofluorescence becomes a little challenging. Although classically it is told to be the gold standard in scrub, but you know, if you are not doing and the kits are not that great, it's not a great thing. So at least for scrub, ELISA works as well or as bad as immunofluorescence assay. Praveen, you wanted
in this case, I just wanted to add, before labeling someone who is not responding to doxycycline, especially orally on OPD basis, it is very important to see any drug interactions. Many times patients take this doxycycline with antacids or divalent cations like calcium, or they'll be drinking milk along with it. So those are the things which we should be sure that patient is not taking doxy with divalent cations, which will decrease the absorption.
Right, I absolutely agree. So we'll
Sir, can I ask one question?
Yeah, please.
How to interpret if it's the wheel Felix OX-K will be 4-fold increase in titer, but IgM scrub is negative. How to interpret that?
So the thing is, in general, what is said is that wheel Felix is supposed to have a higher specificity, but a repeated scrub IgM being negative and OX-K being positive will likely suggest a false positive wheel Felix. It depends upon what the presenting features is, what is your pre-test probability. All serology has to be interpreted in terms of pre-test probability. So with scrub, what helps us is the SCAR. So in most centers, the SCAR prevalence is close to 60%. If you get an SCAR, then you can say that this was a false negative scrub serology because the wheel Felix was positive. But wheel Felix is poor sensitivity, good specificity, but not perfect. So if your repeated IgM ELISA is negative for scrub and the clinical syndrome is not consistent, or we are not able to, if we are able to demonstrate an alternative diagnosis, I would suggest that the wheel Felix is probably false positive.
One small comment is
about wheel Felix. Just the
discovery of wheel Felix serology tests shows itself that, you know, scrub typhus infection produces a lot of heterophile antibodies. So whenever you, in scrub IgM, you are getting actually the recombinant antigens against which you are seeing the IgM. And in wheel Felix, you are doing it with a Proteus strain. So I would, yeah.
So basically, it is again very important that
actually, just to give the clinical context, this patient had a febrile illness with myocarditis, and he went into VF and arrest almost 5 times. The arrhythmia part was managed with mexiletine, but because of the febrile illness and the wheel Felix being 4-fold increase also from, I think it was 160 to 640 or something.
So this 4-fold increase happened in what duration of time?
Within like maybe 2 weeks, sir. in a span of 2 weeks.
Patient had cardiac arrest?
No, he outside partially treated. After he got admitted under us, had VFVT 5 times here in ICU.
No, so again, the thing with in-house tests is that performance also has an issue. So these one-fold, two-fold changes can happen. What you're describing is one-fold, two-fold changes?
Yeah.
How much was the
Four-fold.
Initial was how much?
160 to 640, I think.
160 to
640. And IgM was negative, so
both the
wasn't
times.
sure. I think that was not repeated again.
Just food for thought. Can it be a proteus infection in the ICU, UTI or something like it? Just food for thought or, increased change gut microbiota, increase in enterobacteriaceae in the gut.
Actually, he went to ICU after the arrest, sir. Before that, he was in
No,
the
a good
ward.
thing would have been to do a repeat IgM. If it was persistently negative with a rise in titer of OXK, I would suggest that is false positive OXK, because when you compare both the tests, a specific serology for scrub is more specific than a non-specific wheel Felix test, even if there is a rise in titers. But it could be possible. So if you are doing serology too early, it might be negative at that point of time and you're getting a low titer for wheel Felix, but later on it could have increased. But systematically, if you see, between both the tests, scrub serology works much better than wheel Felix. We use wheel Felix in cases where we don't have specific serology available, like for rickettsial infections, other rickettsial infections, but for scrub, I would go with the scrub serology.
Okay. This patient responded to doxy.
I think this
Initially,
case,
But
there is a little bit
50
of diagnostic
agents.
anchoring, in the sense because you must have given steroids also, I'm very sure, for this patient.
No, sir, we avoided because there was myocarditis.
Steroids.
And, no, initial.
Do we have anything else for scrub other than OXK?
No, so this
No,
could be viral
IgM was
myocarditis that
negative.
improved on its own. There are 50 agents that respond to doxycycline.
Yeah,
So if
it's broad.
the 50 is less probably. There are myriad agents that respond
Yeah.
to doxycycline, including a gram-positive infection that could have gone undiagnosed, or due to the immunomodulatory activity of one of these drugs. So very difficult to say, but broadly, without the full picture is very difficult to say. But broadly, what we can say is that try to put serology in context. That is the
Just to add, I'm yet to see a scrub patient coming with a VT storm, landing up in, have you ever seen, myocarditis we see, but we do not see a patient coming with VT storm. And myocarditis won't respond, in the sense patient might be clinically stable, but then this could be a giant cell myocarditis which requires a very long duration of treatment. It could be eosinophilic myocarditis. So such cases, I think you need a MRI, heart and a biopsy to confirm. That biopsy would have helped you, even if you are thinking scrub, probably you could have done a scrub PCR if the patient is stable. So the story, I think, is not over. The patient is not improved. He might come to again after a year with a DCMP, which we could have probably prevented in this patient. So I think possibility is there, but the other causes of this kind of fulminant myocarditis with VT storm, we should have thought about other possibilities also in this case.
So if for me, if SCAR is negative and there is persistent scrub negativity, I would rather focus on other possibilities also. Doxycycline, definitely should continue, but I would focus on other possibilities.
Before we conclude this session, I just want to say in scrub myocarditis. So the interest trial has shown that combination of azithromycin and doxycycline was better as compared to single agent alone, and I know that it also included myocarditis patients. So the point is the pre-existing cardiac disease and arrhythmias are a contraindication, and some of the arrhythmias can happen because of the myocarditis due to scrub, and in those cases we should not hesitate to give azithromycin. I know that QT interval prolongation is a problem. We need to monitor that, and if we monitor that, it is quite okay to give a combination of doxycycline with azithromycin. And recently, there was another patient. So I was having a discussion with electrophysiologist of our own hospital, whether is there any contraindication to give azithromycin in this patient? So that patient had myocarditis. So he was very comfortable. He said, absolutely no problem, ma'am. You go ahead. You can give azithromycin in this patient. It is fine. So it was just, I wanted to bring it up.
That's a good point, ma'am. Again, the idea was to discuss the difference in
No,
opinion.
I'm just, I want to put my views.
Yeah, of course.
Because...
can you, do you know how many patients of scrub myocarditis were there in the interest trial?
I can't remember. I had gone back, but it had, and there was no increased mortality in those group. And also I want to clarify the composite outcome. So it was composite outcome which included mortality and the recovery in 7 days. And it was not just based on the bilirubin and the creatine values. The most of the difference came from the additional requirement for oxygen. So it was quite a valid thing. It was not just the numbers of bilirubin and creatinine values. It was more of requirement for oxygen which came down with the combination of doxycycline and azithromycin.
No, the argument of composite outcome is completely valid. The counter argument that comes here is that the hard outcomes that were there were mortality and time to defervescence, both of which the other thing was that time to defervescence, the third interquartile range was 25 days for both arms, all three arms. The third quartile range was 25. With a median of 5 days after treatment being started, a third quartile range of 25 is too big.
No, that I agree.
Which suggests that there is some other things going on. Hospital-acquired infection can increase to lead to persistent oxygen requirement, increase in oxygen requirement. So the point being is that this again azithromycin thing, giving or not giving in a myocarditis patient, is something that is probably debatable. The question was that, is the data suggesting that we should do this absolutely, or is there room for interpretation? That's the thing. The trial was absolutely good.
No,
not
I
a criticism for
that,
trial.
I mean, you should definitely individualize when we treat the patient. So, but I just want to
of course, ma'am.
Send that message.
Thank you. So, we'll move on to the next case. So, this is a patient who has come with 50-year-old female, fever, dyspnea, some leg swelling is there, leukocytosis, thrombocytopenia, raised CRP. There was no eschar. Now you would think of scrub typhus again from the previous case. But so now the clinician says that there is no eschar, so this cannot be rickettsial, and therefore doxycycline was not started. The patient deteriorates, there is symmetrical peripheral gangrene now. So the question now is that, does absence of eschar rules out rickettsial infection in India? Bharti, you will start.
So I think, like you mentioned with this previous scrub trials, about 60% of patients have been found to have eschar, and again, eschar is usually in areas where examination sometimes may not be done very well in groin and the underarm and other things like that. So the statement is not true. Absence of eschar cannot completely rule out rickettsial illnesses.
Right.
Yes.
I just want to add here, Dr. Shantan, that there is a study from West Bengal where in patients with scrub typhus, the percentage of eschar was 0%. So, which I think is not possible at all, that all the patients of scrub typhus, there was no eschar. So, very likely either it was a false positive serology or nobody is checking for eschar in West Bengal. So,
I don't take the responsibility for the entire state, but
no, but the idea is that
what I would like to say is our figures, even for PCR positive cases, so pediatric cases we got more PCR positives. Somehow, probably the early sample sending was higher in pediatric cases, and really presence of eschar was low. It was less than half. In all cases.
So we can agree that 50 to 60% of the patients have eschar if they are properly checked. But 0% is definitely not true. But presence of eschar in India suggests scrub typhus. Absence of eschar does not suggest scrub typhus. That is one angle of it. The second point here is that the presence of rashes on palms and soles. So scrub having rashes is not very common, at least what we have seen, right? Although previous literature describe rash as a common feature of scrub, but not very commonly you see rashes, especially on palms and soles. So when you're thinking of rashes on palms and soles, do you think of other infections that could be possible here?
Non-Orientia rickettsial infections.
Right. What are you thinking in terms of non-Orientia infections?
Yeah, the Indians, rickettsial spotted fever.
So the spotted fever typically presents with these rashes in palms and soles, and they have a propensity to cause. Yeah. So in India, basically the point that I wanted to highlight here was that the second most common probably rickettsial infection in India is the Indian spotted fever, which was erstwhile also called as the Indian tick typhus. It's not a typhus, but it's Indian spotted fever, which is caused by Rickettsia conori subspecies indica in North India and some parts of South India. But in South India, there is another species that is commonly found is Candidatus Rickettsia kelly. But it has a propensity to cause these, rashes on palms and soles, like you see in secondary syphilis or, hand, foot and mouth disease.
Can I? So basically, many of the times, this pattern could be more dramatic with actually necrotizing vasculitis, the skin lesions looking very angry. And bedside, many of the times, it is it gives an impression when you are looking at this patient. Are you dealing with something like purpura fulminans, or are you dealing with meningococcal sepsis? But this is very interesting because the spotted fever has a receptors only on endothelium, whereas scrub will have macrophage involvement also. So it is extremely dermatotrophic, involving the endothelium of dermal vessels leading to dermal vasculitis with no hepatosplenomegaly lymphadenopathy, and even the lung involvement is less common compared to scrub. So what you see is a very stable patient, but giving an impression that there is something very bad going in this patient. So most of these patients won't die. None of the patient actually dies. The response to treatment is little later than scrub typhus.
Only thing is that when they develop this peripheral symmetrical gangrene, it becomes very difficult, and most people who die are because of prolonged hospital stay, secondary hospital infection, if they at all die. But very interesting explanation.
So the receptor for the entry for this thing is COO, which is again well described in rheumatology. If someone is having anti-COO antibody syndrome, they look like scleroderma with lupus overlap. This is exactly looks like an acute scleroderma present.
COO is one of the receptors amongst many others, but this is again very typical presentation, something that is not very uncommon.
Yeah.
Can you give her the mic?
That's okay. I just was responding. Just saying that there's an immune mediated along with the infection primarily also. So, I mean, not giving doxycycline was obviously wrong. And we would probably also have to give the steroids in these patients if in case there is a worsening. In case, depending on how the patient progresses.
That's an interesting perspective. What do you think, Praveen? Steroids in these patients?
I think the treatment for all the diseases are steroids. All the medications which we are giving are to prevent the side effects of steroids.
Right.
So steroids will decrease the length of hospital stay.
If you write a book of antibiotics, there will be 990 pages on immunomodulators and 10 pages on antibiotics. Anyway, so this is a patient, again, this is a patient, everybody knows that this is a patient with Weil's disease. You see jaundice and conjunctival suffusion. Patient has some features of, let's say, severe pulmonary hemorrhage syndrome also. Now the thing is that the question is, what the junior doctor has written is, and which we see very often is, the patient should be given IV penicillin. Some benzyl penicillin 1.5 million units 6 hours, nothing else. So my question is that, is IV penicillin mandatory for severe leptospirosis? Are there no other alternatives? Can you not give, let's say, ceftriaxone or doxycycline, or you have to give IV penicillin? This patient is very typical, but there are sometimes, atypical manifestations where you want to give a broad coverage, let's say. You want to give meropenem or piperacillin tazobactam. Would they be okay, or you want to give IV penicillin? Anybody wants to start, Bharti?
So, IV penicillin I think is not very available easily at all from centers where I work. So in most patients with severe lepto or some other confusion, just ceftriaxone is definitely an acceptable alternative, or some patients are even on broader spectrum cover because you're not comfortable with only the diagnosis of lepto with piptaz or meropenem. So I think they definitely are acceptable alternatives instead of IV penicillin.
Right.
In this case.
I would add to this, I mean, just to say what is our general practical, response to patients. We have patients coming in like this way before we get the investigations. What we generally do, and I'm assuming that's what you do, is we start with IV ceftriaxone and add doxycycline also, because we do not know whether it's scrub typhus, it's leptospirosis, what are we dealing with at that point of time. And if there is, and since we have a lot of malaria, we may also consider giving antimalarials upfront. If my understanding is correct from whatever I've read previously, I've not done this recently, benzyl penicillin works better and has better outcomes is what I remember. So that's not right. So then for me in that case, ceftriaxone is fine, and I would give IV ceftriaxone. I will not wait for benzyl penicillin in this patient.
So can I go a little back and ask Praveen, what do you think? There is a Cochrane meta-analysis that shows that antibiotics versus no antibiotics, there is no difference in outcomes in leptospirosis. Only with severe leptospirosis, there is a slight decrease in duration of hospital stay. But outcomes as such have not decreased. So one of the
steroids we have to give.
In terms of antibiotics,
so
the point that I'm trying to put forward is that antibiotic itself, we have not been able to show that antibiotics have significant impact on leptospirosis, but we agree that we want to give antibiotics. In that antibiotic, do we have to be very picky that I want to give IV penicillin? Because commonly what happens here in many places is that somebody is getting, suppose, some broad empiric regimen for supposed sepsis like meropenem or something. People add an additional IV penicillin saying that I want to give IV penicillin because IV penicillin works better for leptospirosis. So first, there is no evidence that IV penicillin works better than anything else. There is no evidence that antibiotics works for leptospirosis. So whatever you give should work, because both doxycycline, piptaz, meropenem, everything works for leptospirosis. But coming to Praveen's
I
point,
think there is a little bit of pride in using IV penicillin so that we can be heroes of stewardship. So there are two antibiotics. One is ceftriaxone, which you can give once a day. Head-to-head compared with IV penicillin early 2000s, found to be equally good. Second thing is whether there is actually role of antibiotics, because most of the times the argument of penicillin comes because the affinity of penicillin to penicillin binding proteins is better than beta-lactam, so you are going to kill the leptospira fastly. But most of the times when the patients with severe leptospira, they come to you, the leptospira will have already been died. And if you are thinking that there is a very high load of leptospirosis at the time of giving penicillin, actually penicillin can be associated with more Jarvis-Hexheimer reactions, which can worsen. So penicillin probably we have to give like 4 lakh units every 4th hourly, and can be associated with Jarvis-Hexheimer reaction. Penicillin sensitivity is a problem. Most likely will have a higher risk of renal injury. So I would any day prefer ceftriaxone for leptospira, not penicillin.
right. The other argument against the antimicrobial stewardship point is giving something that is 4 times or 6 times a day, as opposed to giving something once a day, is definitely better. We use ertapenem as an example for antimicrobial stewardship, that we are giving less times a day. So that's an antimicrobial stewardship. So I think ceftriaxone is a win here.
There is a misconception that there is no
Within
RCT.
last 5 minutes.
We'll finish it off.
There is no RCT comparing penicillin with ceftriaxone. That's a misconception.
Yeah, exactly. No,
but
that's
there
what.
is enough data to say that ceftriaxone is good.
That's what. So I've put some references here, but I think so. We discussed the KFD phase 2. So the KFD phase 2 comes with meningoencephalitis. Now this is a little nuanced question, because you know the KFD is a tick-borne infection, and ticks often have a propensity to carry multiple infections at the same time, right? This has been seen with a lot of cases of Lyme disease, where there was simultaneously some anaplasmosis, ehrlichiosis happening in many of the patients. So including in India, when we looked for Lyme disease, we found that a lot of these patients had other infections as well. So ticks have a propensity to carry multiple infections at the same time. When somebody comes with KFD phase 2 meningoencephalitis, at that point of time, there is a possibility that this could be a bacterial infection that the tick had transmitted, and that is now causing infection. Do you think there is any point of investigating or trying and giving some treatment to these patients, or we know that KFD phase 2 meningoencephalitis does not require antibiotics, so we just don't?
I will take this question because I am the only one working with KFD in the panelists, senior most. So basically we know that all the KFD patients with phase 2, they will eventually improve. So the question of treating phase 2 KFD should not be whether the patient is going to improve or not. We all know that patients are improving. But each time patient is getting admitted into the hospital, they sometimes stay for a week, sometimes it will take 10 days, they will have some fatigue, cerebellar symptoms, and that is actually that is stretching the healthcare requirement, where many other times we don't have enough beds for other patients. So the research should be focused on coming down on the duration of illness. And now that we kind of know that KFD second phase is immune mediated, doxycycline could be a good immunomodulator, but we have to look into the other aspect. Right now we are not rating, but I think there is a definite requirement of cutting down the duration of second phase of KFD.
So the message here is that antibiotics are not required for phase 2 meningoencephalitis, but we have not encountered with any case where we don't test for it also, but most of our, in fact all of our phase 2 patients recover. But this is a possibility that can happen, but it's just a theoretical possibility. So antibiotics for meningoencephalitis, not giving antibiotics is something that I know is counterintuitive to people who do not manage KFD. But if you have a clear-cut diagnosis of KFD, no point of giving an antibiotic. And this is a very straightforward, I think we'll finish with this, that this is a patient who has come with, feature suggestive of spondylodiscitis. And in India, spondylodiscitis means TB. This is something that has been traditionally ingrained in many medical hospitals across the country. So he was started on ATT and did not improve at 8 weeks. So my question is that, again, we all know the answer, but all spondylodiscitis in India is due to TB. And anti-TB should be default therapy for all of these patients. Do you agree or not, and what are the points?
This is the myth here. I will obviously know that you want us to disagree with it. So the first thing is that as part of evaluation, since it's a pharma, we would look at other possibilities like brucellosis, because that was initially at the bottom of your panel. So that is the answer to this. So we'll need to look at that. And of course, we would like to, maybe aspirate the epidural collection if that is possible, or psoas abscess if that is possible. I do know that you have done a paper on the radiological manifestations of spinal brucellosis. So you would say that that will be telling us that it's brucellosis. We don't need anything else. But I would like to also look at possibility of drug resistant.
Let us go into a little bit in this question.
I would like to look at the possibility of drug resistant tuberculosis also, and thereby initially if there is something that can be aspirated, I would like to aspirate it and send it for culture and DST, LP, etc. And then of course if it is not responding, we do think of things like brucellosis. It is not just that spondylodiscitis is TB. So yeah.
Right. No, to understand this better, can you give an idea of all the cases of spondylodiscitis, infectious spondylodiscitis that you see in your center? How many of them are undiagnosed? How many of them are diagnosed? And amongst the ones who are diagnosed, what is the proportion of TB versus other infections?
So I do not have exact numbers.
No, grossly.
Grossly, most of our patients end up being tuberculosis. They do respond to anti-tubercular treatment as well. Brucellosis, those patients who are coming to us, since we do see quite a lot of brucellosis, we have a higher index of suspicion, and there is that bias since the patients are coming to us referred, already not responding to anti-tubercular treatment. So we then look for brucellosis in these patients. We send the serologies. We look for other evidence of brucellosis in any other place, the history, and then we discuss with the radiologists and then decide to treat as brucellosis if they have not responded. But most of our patients, I would say 60 to 70% or more is tuberculosis when they come to us with spondylodiscitis.
You're saying 70 or more percent is TB. Bharti, what do you think is the TB in your center, approximately?
With spondylodiscitis, again, when in our center, because most patients are referred, we do always try to get a sample if possible and try to work up for etiologies before giving a trial of empirical ATT. But what usually happens is if nothing else is positive, we do give an empirical trial of ATT. So I would say about 50% do get ATT and have responded to treatment. But there have been some brucellas also which we have picked up because of
any
evaluation.
Approximate idea of what do you think is the proportion of TB patients?
I think maybe about 50% would be
50%.
Yes, but because we also have seen sometimes staph, some brucella and other things also as presenting as chronic spondylodiscitis.
Right. Dr. Shantan?
So we sample all the cases of vertebral discitis, and our positive yield is not that great. Our even if we sample, we get about 60.
Sample means radiologically or
radiologically?
Surgically?
No, radiologically. Not surgically. If there is indication of surgery, if there is a significant compression, if the surgical sample is available, the diagnostic yield goes higher.
Right.
But radiological biopsy,
So what percentage undiagnosed in your radiological yield?
40% undiagnosed, 50 to 60% diagnosed.
Of those diagnosed, how much is TB?
Again, 50 to 60% is
50%.
TB. So total, among all the cases, our TB will come down somewhere around 40.
Right.
30-40%, and we get a lot of staph, staph aureus as well as staph hemolyticus.
Right.
We have got 2-3 staph epidermidis, but that grew very quickly from the samples. So, yeah.
Right.
I would like to add some causes which we don't think which will not come into our mind that this could be cause of most of the times when we are thinking, we think about Staphylococcus, Salmonella, NTS, Brucella, tuberculosis. But Candida is one more important cause of spondylodiscitis, and that will have a granuloma. Most of the times granulomatous candidiasis, it's very difficult to prove it culture. So the history of recent hospital admission, candidemia during
Candida,
hospital admission.
Aspergillus,
And mycoplasma. Mycoplasma spondylodiscitis can also cause pus, and especially patients who are immunosuppressed, recent genitourinary intervention, that can actually lead to a subsequent mycoplasma septic arthritis or mycoplasma spondylodiscitis. So mycoplasma and Candida, very rarely, probably we have seen 1 or 2 cases of Aspergillus
we've seen
spondylodiscitis.
Aspergillus, yes. Melioidosis is another.
Melioidosis is another possibility.
But so what I wanted to bring out here is that we in our center we have a good orthopedic team, so they do open biopsy for all the patients. Yes, so the yield is definitely better. This is again, I have talked to radiological friends and this has been shown in previous papers that as compared to I'm not saying whether that's recommended or not, but as compared to radiological guided biopsy versus a surgical biopsy has a much better yield. So in our center, the proportion is less than 50% is TB, some 20-25% is Brucella, and the others are the myriad of pyogenic organisms like staph.
So now, what are you practicing? For every case you are going for open biopsy?
This is what happens most of the times here. Now I'm telling you how we are evolving. So with this baseline data, we have worked on some scoring systems.
No, that, yeah.
So which works very good. It has good diagnostic accuracy, which tells us that there is a good chance of this being TB. You can treat them as ATT. There is a good chance of this being Brucella versus pyogenic. For Brucella versus pyogenic, our standard agglutination test works very well. None of the patients who had a standard agglutination positive and we treated as Brucella did not improve, right? So most people with this has good diagnostic accuracy, at least in our setting. Other thing is that what we try to do is that there are other sampleable things. For TB, you can have cervical lymphadenitis or pulmonary lesion is there concurrently. For pyogenic, usually, often you have like some skin soft tissue infection or a genitourinary infection, E. coli Klebsiella that is going up from there and stuff. So, or blood culture is positive. So, there are other things that can help you make a diagnosis without doing a biopsy. Again, if there is a need for a surgical spine stabilization or debridement or something, then obviously you'll go for it. But if a lot of our patients are not able to afford it, there we use the scoring system. Some basic things that we have understood, and this which is there throughout the literature, is that TB has a propensity to involve the lower thoracic vertebra, whereas pyogenic and Brucella have a propensity to involve the lower lumbar vertebra. So L3, L4, L5, sometimes sacroiliacs and these things might be there. If there is a lot of epidural abscess or paravertebral abscess, big in size, we have some cutoffs. It suggests more towards TB. If the duration of illness is longer, which suggests towards TB. So there are things that can help you point. So instead of going empirically as ATT, which is a lot of people practice this, giving ATT, and what happens is that ATT has rifampicin, which might have some incomplete resolution of treatment. So when we are not sure, we definitely go for a biopsy, whatever radiological or surgical, whatever is available in your centers. But we try to make a diagnosis and then give a empiric therapy. The idea behind this is that brucellosis is not uncommon. With this, we will just, there was a... So now what happens is that a lot of this is that we see the MRI, we know where it's pointing towards. Pretest probability of Brucella pyogenic is high, we do a SAT. If SAT is positive, at least what I practice is where I don't, if there is no need for spine stabilization, then I don't need to go for a biopsy and treat the patient with Brucella. Response is usually good. If not, if SAT is negative and I don't have a diagnosis, then question is TB versus pyogenic. Are there other sources of pyogenic or not? Can you diagnose TB through other sources or not? If not, then here in our center, radiological surgical biopsy is what is preferred, and the treatment pathways are aligned that way. So we go for surgical biopsy in that case. But you're right that the question is again yield versus ease. So for us, yield works better, but there is no hard and fast rule. So I think there are some other questions on typhoid that we can discuss later. With this, I thank all the panelists for participating so enthusiastically in this discussion, and also the audience who are here offline and online. So we'll break for lunch. During the lunch, Shivdas is going to do the quiz screening.
May I request Dr. Moderator Verma, Professor and Head of Department of Infectious Diseases, Kasturba Medical College, Manipal, to present mementos to the esteemed panelists as a token of gratitude and appreciation for their valuable insight in the panel today. Thank you. Dr. Sayantan Banerjee, Additional Professor and in charge ID Services, AIMS Kalyani. Dr. Bharati Arunan, Consultant Infectious Diseases, Narayana Health City, Bangalore. Dr. Kutti Sharada Vinod, Associate Professor and Unit Head Medicine, AIMS Mangalagiri. Dr. Praveen Kumar Tirlangi, Associate Professor, Infectious Diseases, KMC Manipal. Dr. Nitin Gupta, Associate Professor, IFT, Infectious Diseases, KMC Manipal. We'll now move on to the next session, which is the prelims for the quiz competition, which is going to be conducted by Dr. Shivdas Naik, sir. Others can go for lunch. Those are not participating can go for lunch. Others can break for lunch now. The prelims for the quiz is going to be conducted on a web-based platform. It's going to be MCQ-based screening. The correct answer will fetch marks and the faster answer gets more marks. You'll also see the live leaderboards, and the top 5 teams will be selected for the main rounds.
अपना लगा ले मुझे, give me 2 minutes.